Okay, it is now my pleasure to introduce Dr. Daniel Clauw. Dr. Clauw is a professor of anesthesiology, rheumatology, and psychiatry at the University of Michigan. His research interests include fibromyalgia, chronic pain, mechanisms of pain processing, functional somatic syndromes, opioids, and cannabinoids. Dr. Clauw completed his internal medicine residency and rheumatology fellowships at Georgetown University, where he eventually held roles including chief of rheumatology and vice chair of medicine. While at Georgetown, he formed the Chronic Pain and Fatigue Research Center to investigate how to best diagnose and treat chronic pain. The group's aim is to study the central nervous system's contributions to chronic pain disorders, including fibromyalgia, low back pain, and Gulf War illnesses. Dr. Clauw later brought the Chronic Pain and Fatigue Research Center to the University of Michigan, as well as worked to grow the university's clinical research infrastructure. Welcome, Dr. Clauw. We're so excited and so honored to have you. I'm going to stop sharing my screen so that you can take control now.
Well, I'd love to, but let me see where the PowerPoint is.
And Dr. Clauw is joining us from the East Coast, where it is now evening time. So thank you so much for giving a bit of your evening to us.
Can you see that now?
Yes. Perfect.
Okay, so my title was a little simpler than the one that you chose, but I am going to talk about all of those things and really focus on what we've learned, especially in the last 5 to 10 years, about diagnosing and treating individuals that have chronic pain. Disclosure slide, I actually do a lot of consulting with pharmaceutical companies that are trying to develop new drugs, especially non-opioid drugs. You see at the bottom, I really don't like opioids at all. I think they've really caused a lot of problems in the United States. And we'll talk about all the options that are available to manage chronic pain other than opioids. So every talk I give, I start with these slides. And by the way, the slides I'm using today are largely the same slides that I will use to give a talk at an international scientific meeting or at a medical conference. But I give a lot of talks to patients, and so I can use the same slides, but say things differently. So hopefully you'll be able to understand everything that I say. So these are two individuals, different individuals' knee x-rays. And when I was trained 30 or so years ago as a rheumatologist, we thought that the person on the right would always have pain because his or her knee joint was basically destroyed by arthritis and there was bone rubbing against bone. And that the person on the left would never have pain because that's an entirely normal knee joint. And this condition that I happen to be talking about right now is osteoarthritis, but everything that I say today about osteoarthritis, I'll also refer to studies that have been done in rheumatoid arthritis. Really, all these things apply to individuals with ankylosing spondylitis, spondyloarthropathies as well. So the first thing I want to dissuade you of is the notion that you can see pain on an x-ray, because it turns out that starting about 30 or so years ago, it became clear that there was a terrible relationship between what you see on x-rays and whether someone's experiencing pain and how severe that pain is going to be. So about 10% of the people in the United States population that have knee pain will have an x-ray like the one on the left. They'll have knee pain, but they'll have an entirely normal x-ray. But what's even more striking is how many people that have this x-ray that where basically this is advanced osteoarthritis of the knee, bone on bone, and about 30 or 40% of the people that have this x-ray don't have any pain whatsoever. And so I always start by showing the disparity between radiographic findings and pain. But I'm using an example of osteoarthritis of the knee. Our research group does funded research in at least 15 different chronic pain conditions, and there's not a single pain condition where anything you can see on an X-ray or an MRI or any kind of test that we can do accurately predicts how much pain someone's going to be experiencing. And you certainly can't tell that from an X-ray. So this is my 30 or so year career from when I started in rheumatology, and I was taught that osteoarthritis was the classic peripheral pain condition. This was actually before those studies were done that I just alluded to. Then in the 1990s, the studies were done showing that there was a really poor relationship between structural abnormalities and the presence of pain and the severity of pain. When doctors or healthcare providers see people that have pain and they can't understand what the pain is due to, they typically will blame psychological factors. But it turns out that psychological factors actually don't explain the difference between how much pain someone with osteoarthritis is having and what their knee x-ray looks like. And another thing that's happened is that over the last 3 decades or so, some of the treatments that I was taught almost always worked when people had inflammatory arthritis or osteoarthritis. Non-steroidal anti-inflammatory drugs, acetaminophen, which also goes by the name Tylenol, opioids, even knee replacement surgery or joint replacement surgery do not predictably relieve pain. Only about a third of individuals that we give drugs like non-steroidal anti-inflammatory drugs will actually benefit. But so 2 out of 3 people that get NSAIDs really don't get much benefit from those drugs at all. And even joint replacement surgery, if the problem in pain was always a problem out in the joint, then joint replacement surgery should almost always relieve pain. But about 30% of people with knee osteoarthritis that have joint replacement surgery don't have improvements in their pain. So we know that model is fundamentally flawed. The good news is now we really have a pretty good understanding of why it's flawed, because we were really only sort of looking at one component of pain, and that is what was going on out in the periphery. So now I'm going to segue to talking about fibromyalgia. Our group is arguably the leading research group in the world in fibromyalgia. We did more than anyone to legitimize fibromyalgia as a real condition. But that's not what I'm here to talk about. What I'm here to talk about is that fibromyalgia now is really more than fibromyalgia. A couple of years ago, the international group of pain researchers called the International Association for the Study of Pain actually said the same features in the central nervous system that are prominent in conditions like fibromyalgia are prominent in almost every chronic pain condition. There'll be subsets of individuals with psoriatic arthritis, rheumatoid arthritis, lupus, or fibromyalgia that really have pain that is coming more so from their central nervous system or their brain rather than from the area of the body where they're experiencing pain. And so we got a lot of things wrong about fibromyalgia. The first criteria for fibromyalgia, we counted how many tender points people had. And by the way, we now know the tender points are stupid, so we don't have to count tender points to diagnose fibromyalgia anymore. It is true that a lot of people with fibromyalgia are tender, but one of the big problems with the original criteria for fibromyalgia that required both chronic widespread pain and a certain amount of tenderness is that women are a lot more tender than men. And I'm going to talk about that, but it just is innately the case biologically that women are more tender than men. So one of the really big problems with the first fibromyalgia criteria that required performing a tender point count is that fibromyalgia using those criteria was an almost exclusively female disease. And then that allowed fibromyalgia to continue to be sort of stigmatized because most physicians were male, and they would just basically look at a female that had these symptoms and not believe they were actually even real until our group and others started to use functional brain imaging and other studies in the early 2000s to show what really was wrong with people with conditions like fibromyalgia. So there were a lot of things we got wrong in the first definition of fibromyalgia. We thought people either had fibromyalgia or didn't have fibromyalgia. We thought that the tenderness was confined to these dots, but people with fibromyalgia are tender all over. It doesn't matter where you're pushing someone with fibromyalgia, they're more tender than someone that doesn't have fibromyalgia. But in the old days, in 1990, the pathophysiology was poorly understood, and most healthcare providers either thought fibromyalgia didn't exist at all, or thought that it was primarily a psychological problem. And now if we fast forward to present, Fibromyalgia is the poster child for what the International Group of Pain Researchers now agrees is a third mechanism of pain. We've known about two pain mechanisms forever. Pain that is due to damage or inflammation in the area of the body where you have pain. You burn yourself, you hit yourself with a hammer, that's supposed to hurt you, and it does hurt. The second type of pain is nerve pain or neuropathic pain, but this third kind of pain, which used to be called central sensitization or centralized pain, now the term is called nociplastic pain. I don't like the term. We actually wrote an editorial saying we hated the term, but the term is here to stay, so we're all going to have to get used to it. But this construct of nociplastic pain in the last 30 years is now really well agreed upon by the International Group of Pain Researchers, and we understand what's driving or causing conditions like fibromyalgia and this type of pain fairly well. It's not at all the case that there's no objective abnormalities in individuals with fibromyalgia. In fact, if you do things like functional MRI or functional brain imaging, you can tell with over 90% sensitivity and specificity who's the fibromyalgia patient, who's the control. It's just that those tests are not yet available to be used in clinical practice. So I'm going to use an analogy now that I started using about 15 or 20 years ago, because I actually give talks every couple of weeks to chronic pain patients. I used to do it in a big room. I haven't been able to do that for the last couple of years, unfortunately. But the analogy that I'm going to use here is that the pain processing is a lot like an electric guitar. And what I mean by that is there's really two ways to make an electric guitar louder. You can either strum the strings harder, or you can turn up the amplifier. If I superimpose those two knees that I showed you earlier, just imagine that the strings in the guitar are the equivalent of all the different nerves that you have that go to different areas of the body. And in this case, the analogy is the knee. Some nerves pick up heat and cold, some pick up pressure, some pick up inflammation, but you have all these nerves that go to all these different areas of the body. And these nerves are responsible for telling what's going on in those different areas of the body. But the information from those nerves, all the information comes up through the spinal cord and up to the brain. And the only organ you need to have pain is the brain. We've known this for a century, that people could have phantom limb pain, that they could have pain even though that limb no longer existed. So it turns out that it's not just the brain, but the brain and the spinal cord have a lot to do with whether you're going to feel something to be painful or feel it not to be painful. So each human has the equivalent of their own amplifier setting. And if you happen to be unfortunate enough to either be born with a low amplifier setting or you acquire a low amplifier setting, you don't get enough sleep, you don't get enough exercise, you're under a lot of stress. There's a lot of different things that will cause these processes or this amplifier problem to get worse. Then what happens is that even if you don't have anything wrong with your knee, as occurs in fibromyalgia, because of the fact just that your amplifier is set so high, you can have pain. And the other thing that I like about this analogy is it also reinforces that things like fibromyalgia or nociplastic pain are not either or. It's not like people either do have fibromyalgia or don't have fibromyalgia. Everyone has the sort of their amplifier setting. Let's say that human amplifiers go from 0 to 100, and the average fibromyalgia's amplifier setting is at 90. If you happen to have an amplifier setting that is at 70, that is higher than average, but not something that we would call fibromyalgia, you'll feel a lot more pain for the same amount of damage to your joint, or with the same amount of pressure applied, or with different things that happen to you. And the other reason that I really like this analogy, this amplifier analogy, is one of the other things that we've learned is one of the hallmarks of these conditions, these nociplastic pain conditions, is that the amplifier isn't just set too high for pain processing, it's set too high for all sensory processing. So one of the best ways that I can tell sort of where someone is on this amplifier setting is there's a lot of ways I can tell. I'll talk about those different things, but one of the sets of questions that you might be surprised by that I would ask you if I was seeing you as a patient is, and by the way, I don't see patients anymore, so please don't try to see me as a patient because that won't happen. But I would ask you, are you sensitive to the brightness of lights? Are you bothered by odors? Do you have a lot of side effects of drugs? Do you think you're more sensitive in different areas than other people? Because what we've learned is that the brain regions that increase pain sensitivity in people with fibromyalgia in the brain also increase sensitivity to these other types of sensory stimuli, like sensitivity to light, to odors, to drugs, and things like that. And then finally, the fact that this problem, nociplastic pain, seems to be coming from the brain or the central nervous system, gives us other symptoms that we look for other than pain, and those are fatigue, sleep problems, and memory problems. Those types of problems travel with the pain and the sensitivity to light and sound and noises and drugs that we see with people with nociplastic pain. So it's this, none of this is yes or no, just like an amplifier setting is not on or off. And so what happens is that in most individuals, their pain is driven by a combination of something that's going on out in the periphery. In the case of, if you have psoriatic arthritis or psoriasis, you have inflammation out in the periphery that would be driving pain. And you're taking medications and you're doing other things to try to decrease the activation of these nerves that are being activated because of the inflammation in the knee. But the other big thing that is a target for treatment, which is why it's good for people to understand that you sort of have to add together what's going on in the amplifier and what's going on in the guitar, is that most people with chronic pain also have a higher than average amplifier setting. Chronic pain sort of causes people to have higher amplifier settings. So some of the treatments that we use for chronic pain are really aimed more so at turning down the volume control in your amplifier rather than necessarily attacking things out in your knee. So this isn't like either or you either have fibromyalgia or you have spondylitis. The overwhelming majority of people with spondylitis have a little bit of fibromyalgia. Some have a lot of fibromyalgia and some have a real lot. And the more you have, the higher your amplifier, the more symptoms you're going to have. But having more fibromyalgia, more nociplastic pain, a higher amplifier setting, to me is an opportunity, because there's a whole different set of treatments that I can give you to try to turn down your amplifier than trying to give you all these drugs that are really aimed at reducing the activity of your immune system, which is hyperactive if you have a condition with like psoriatic arthritis. But we know that up to a third of people with psoriatic arthritis, even after the inflammation is well controlled, will have nociplastic pain, fibromyalgia, central sensitization, and that again can benefit from different types of treatments. So you see what I've been talking about here, 3 types of pain. Nociceptive pain is pain that is due to damage or inflammation, and there's a certain set of treatments that work for that kind of pain. Non-steroidal anti-inflammatory drugs actually work fairly well if there's inflammation out in the periphery, because they work on by reducing inflammation. Injection into your knee if there's inflammation in your knee can help. Surgery on your knee can help if the pain is coming from your knee. But we know that going back to what I said, those 30% or so of osteoarthritis patients that don't get better when they have surgery, I'll show you some studies that we did just very briefly, that it's because a lot of those people that had surgery, their pain was probably coming from their brain, but we operated on their knee and not surprisingly, they didn't get better. This also is responsible for a lot of people with autoimmune diseases like spondylitis to be unresponsive to biologics, because the problem is no longer that the immune system is too active. That's what those drugs attack. The problem is over here that you've also developed nociplastic pain. You have your pain's more widespread. You have sleep problems, fatigue, memory problems, sensory sensitivity, and we're going to have to use a different set of drugs, and we're going to have to more aggressively use non-drug therapies. I'm going to talk a lot about how helpful non-drug therapies can be. This is an article that came out just a couple months ago, and this is the first big review article in Lancet. It's a journal like New England Journal, the 2 big general medical journals. And so for the general medical field, they're just getting introduced to this new term of nociplastic pain that I'm talking to you about. But the good thing for you as patients, if you have a condition where this is a component of your illness, is that people are going to start to understand this more. It'll have more credibility. They won't be so sort of stupefied when you come in and you still continue to have pain or fatigue or sleep or memory problems, in spite of the fact that your labs look normal, because they've made your inflammation go away with the drugs that they've given you, but they haven't really treated this other component to your pain. There's another new term that's being used, and I don't like introducing a bunch of new terms, but it is what it is. You have the slides, you can look at these afterwards. Chronic overlapping pain conditions is that the National Institutes of Health about 3 or 4 years ago said, you know what, we've been funding research on like a whole bunch of research on headache and a whole bunch of research on fibromyalgia and a whole bunch on irritable bowel and a whole bunch on TMJ disorder and the yada, yada, yada. And it's really looking more and more like all of these are sort of the same problem that just presents in different areas of the body. And so that's really what we're starting to see, is that the predominant pain mechanism in all of these, if you will, pain conditions is nociplastic pain. They just happen to differ in what the name we use and the location of the body where the pain happens to be. But one of the best determinants of whether you have nociplastic pain or not is how many different regions of the body you had chronic pain in, for example, before you developed psoriatic arthritis or a spondylitis. Because if you, for example, in your teens or your 20s had headaches, you had painful menstrual periods, you had some irritable bowel, some temporomandibular disorder, some bladder pain, then what that was is sort of saying you have this kind of pain even before you had developed ankylosing spondylitis, and you certainly then, that would put you at very high risk of then having that kind of pain sort of superimposed upon a spondylitis as well. Because again, down at the bottom here, what you see is this nociplastic mechanisms occur fairly commonly in individuals with ankylosing spondylitis, rheumatoid arthritis. Again, at least 30% of people with a established autoimmune disease will have sort of the same problem as people that get labels like fibromyalgia or irritable bowel. The new criteria for fibromyalgia don't require doing a tender point now, and I'm going to highly recommend that you, while this slide is up, that you fill out this for yourself. I'll show you how to score this, but on the left, we ask people to mark and check the different areas of the body that they have pain. There's 19 boxes on the, and basically just check the sort of region. If you have pain in the head and it's not really right at the jaw, then just check over there. But it's basically trying to look at how many different areas, how widespread is your pain on the left side of the measure. And on the right side of the measure, it is asking about these key symptoms: fatigue, memory problems, and sleep problems. And these actually get scored 0, 1, 2, or 3, depending on whether you say you don't have that, it's slight, it's moderate, it's mild. So you check over here, you get 0 to 19 boxes you check, and that's 0 to 19 points. Over here, 0, 1, 2, 3 for fatigue, memory problems, and sleep problems, 9 points, and 1 point each for pain or cramps in the abdomen, which is essentially irritable bowel, depression, or headache. So there's a total of 31 points. And now the new criteria for fibromyalgia is that if someone scores 13 or greater, they have fibromyalgia. But I want you to ignore that number of 13. Just act like I didn't say that, because 13 is a totally arbitrary number. It doesn't matter what the number is. The higher the number, the higher your volume control, and the higher proportion of your pain is coming from the central nervous system and might respond to these types of treatments that maybe you haven't gotten because people didn't think of treating anything other than the inflammation that you have in your spondylitis. Fred Wolf was a rheumatologist that coined the term fibromyalgia-ness instead of fibromyalgia to say, we really shouldn't think of this as present or absent. And I like giving Fred credit because he's totally right about this. He's wrong about almost everything else he thinks about fibromyalgia because he thinks it's way more psychological than it is. But again, he was the first to say we should really think of different people having different degrees of fibromyalgia, different sort of amplifier settings. And this is another way of showing you this. If you, again, went into a physician or a healthcare provider and you had pain in your knee, and you only had pain in your knee, that would be one kind of pain. And you could almost imagine, if you were a surgeon, that if someone had pain in their knee and they didn't have pain anywhere else, that person, if you did knee replacement surgery, would probably do better with relief of their pain than if you did knee replacement surgery in this person. So this is someone with fibromyalgia, but I'm just showing the two ends of the spectrum to show that when someone has pain all over their body and you just do a surgery here, you're probably not going to have nearly as much benefit as if the only problem they have is in their knee. But everything in between is important. And again, this is why we realize that it's really the degree of fibromyalgia. And the people that actually carry the label fibromyalgia, the tip of the iceberg, many of you don't know you have, again, a component of fibromyalgia or a component of nosoplastic pain, perhaps until today. But again, please don't view it as something negative, view it as something positive, because I'll also tell you all the different things you can do to make it better. But again, centralized pain, nosoplastic pain, a lot of people that have this carry labels like rheumatoid arthritis, lupus, sickle cell disease, low back pain, but the fundamental problem is essentially the same as it is in someone with fibromyalgia. This is another article that came out recently that I was involved in, another Lancet article, and it just talked about how in every chronic pain condition, the old term central sensitization, the new term nosoplastic pain, markedly affects what's going to work. The more central sensitization that someone has, the more their pain is coming from the central nervous system. Again, the less well surgery is going to work, the less well biologics and disease modifying drugs are going to work, because those are all working at attacking the inflammation out in the periphery. They're not at all working at really attacking the central nervous system problems that people develop. And this is just a figure from that Lancet article. And again, spondylitis would be in the middle here, the middle temperature. Not everyone with spondylitis has central sensitization or nosoplastic pain, but a lot of them do, just like a lot of people with rheumatoid arthritis and Ehlers-Danlos and low back pain do. And if you do, again, there's a whole nother set of drug and non-drug therapies that might be of benefit to you. Just showing you how powerful these effects are. We did some studies in people getting knee replacement surgery for osteoarthritis, and we gave the people on the day of surgery that fibromyalgia measure. And there were two things that we hypothesized. We hypothesized that fibromyalgia measure that people filled out on the day of surgery would predict how much opioid someone needed to control their pain. So the other thing about this type of pain, fibromyalgia pain, nosoplastic pain, is it doesn't respond at all to opioids. So if you have pain that when you go, you have a flare, when you go to an emergency room and they give you an opioid and the opioid doesn't make it any better, you have fibromyalgia. You have that kind of pain, because that is, it doesn't really, in fact, long-term opioids will make fibromyalgia types of pain worse rather than better. But for this particular study, we actually were interested in acute pain, how much opioids people needed to control their pain from an acute surgical procedure. And then more importantly, what should we have done knee replacement surgery on that person? How much pain relief did they get from the procedure 6 months after the procedure? So we gave people that fibromyalgia score, and we showed that each 1 point increase in that fibromyalgia score that I had you fill out earlier led to one hydrocodone or Vicodin more being needed to control people's pain just in the first 24 to 48 hours. Each 1 point increase in the fibromyalgia score led to people being 25% less likely to have a meaningful improvement in their knee pain 6 months later. And these were largely independent of psychological problems, and they were linear. Like each 1 point, there's nothing magical about 13. The higher your fibromyalgia score was, the less responsive you were to opioids, and the less responsive you were to having a surgical procedure to make you better. And then after we did these studies in individuals with osteoarthritis getting knee replacement surgery, we did the exact same study in women getting a hysterectomy for pelvic pain, and the findings were almost identical. The increase in opioid non-responsiveness and the decrease in responsiveness to surgery were almost identical. Higher fibromyalgia scores, opioids don't work, surgery doesn't work. This is from one of those studies of knee replacement surgery. Just look at these two people that got knee replacement surgery. One guy has a fibromyalgia score of 12 because he has, in addition to pain in his knee, he has pain in a couple other areas of the body. He has some fatigue and memory problems, and his score happened to be 12, not the bright red line is 13. Being on the right side of the red line would be you have fibromyalgia. Patient A here has just pain in his knee and only has a fibromyalgia score of 2. Look at how different these people are than when we give them knee replacement surgery. Patient B, again, he doesn't have fibromyalgia because you'd have to be on the right side of the red line to have fibromyalgia to be over 13. But look at how different they are. This person is way less responsive to opioids, needs like 8 hydrocodone more in just a 24 to 48 hour period to control his immediate postoperative pain, and is 5 times less likely to get better if he gets knee replacement surgery than if he gets knee replacement surgery. Just because, again, less of his pain is coming from his knee and more of it's coming from his brain. So going back to this diagram that I've showed you over and over again, all pain conditions have different types of pain. And we used to think that all the pain in an autoimmune disorder like rheumatoid arthritis or lupus or spondylitis was inflammation. And now we know that, yeah, inflammation is a problem, but this is a big problem in a lot of people. And if you don't recognize and treat this, then the people aren't going to get better. The drug Duloxetine, which you may know as Cymbalta, is a drug that really can be helpful for this kind of pain, one of many drugs. And this is a study that just shows in people with low back pain, if they just fill out a body map and the more sites of pain they have besides the back, the more likely Duloxetine works. Going back to my electric guitar analogy, if you have a high amplifier setting, strumming any of the strings on the guitar would be louder. And that's why, again, what the fundamental problem is, the higher your amplifier setting, the more places you're going to have pain in your body. Because again, the fundamental problem is not out in the strings, it's a guitar, it's an amplifier problem. So how do we know all this? How do we, know that this is real, that this is, well, again, the last 20 or 30 years, there's just been a tremendous amount of research in chronic pain. Our group has really been fortunate enough to get a lot of funding from different funding agencies and do a lot of this work, but there's a lot of really good pain research groups around the world. This is the first functional MRI study done in fibromyalgia. It was done by our group when we were still back at Georgetown, published in 2002. And this study went a long way to convince people that fibromyalgia was a real disease, because it was the first time that we could actually show that people weren't making this up, that when fibromyalgia patients were given a low amount of pressure to their thumbnail, and healthy controls were given the same amount of pressure, that amount of pressure to the healthy controls, they said it was only a 2 out of 20 on a pain scale, but the same amount of pressure to the fibromyalgia patients was a 11 out of 20 because it hurt a lot more. They were more tender, they had a higher amplifier setting. But this study allowed us to show that. It actually showed that the people that had fibromyalgia, their brains looked exactly the same when we gave them the low pressure stimulus as when we gave the controls the high pressure stimulus. And really, study after study now, the results of this particular study have been replicated at least 20 different times in fibromyalgia alone. But then we see this in subsets of people with any chronic pain condition. We also see that the degree to which different brain regions are either too connected to each other or not connected enough to each other changes. Even the size and the shape of the brain changes in these chronic pain states that involve the brain. We used to think, when I was trained, I'm old, when I was trained in medical school, we thought the brain stopped growing at age 20. You lost brain cells after age 20. We know now that the brain's constantly changing. It's called neuroplasticity. And we think that these fairly dramatic changes in the size and the shape of the brain, especially in areas of the brain that process pain or sensory information, are probably just the brain's way of sort of adapting to longstanding chronic pain. It's called neuroplasticity. Again, I alluded earlier that fibromyalgia is real. This is a group, Tor Wager's group, that showed that if they did functional MRIs in people with fibromyalgia and they took fibromyalgia patients and healthy controls and then mixed up the functional MRIs, they could tell with over 90% sensitivity and specificity who the patients were and who the controls were. And this, and again, it says multi-sensory because they didn't just give people painful stimuli, they looked at how sensitive they were to the brightness of lights. In our group, likewise, when we put people through these types of studies, give them all types of different sensory stimuli, because you can see that the brain regions that are involved in telling you sort of what how bright a light is are the same brain regions that are involved in telling you like how painful something that's coming from some stimulus in the periphery is. There haven't been nearly as many studies done in psoriatic arthritis or in spondyloarthritis looking at comorbid nosoplastic pain as there have been in rheumatoid arthritis. This is a series of studies done by Yvonne Lee showing a bunch of things, but down here, one of the drugs that's actually approved for use in fibromyalgia, milnacipran, which is a drug, goes by the name Savella, a lot like the drug Cymbalta. This drug actually worked well, but it only worked in the rheumatoid arthritis patients that had really good control of their inflammation. So we wouldn't use a drug like milnacipran or duloxetine to treat psoriatic arthritis or rheumatoid arthritis during active inflammation, but it just showed that this residual pain that these people with rheumatoid arthritis have after the inflammation is well controlled really acts exactly like fibromyalgia. This is another study we did with Neil Basu in Scotland that showed that if you do brain imaging in people with rheumatoid arthritis and you give them that fibromyalgia measure that I showed you earlier, the higher they score on the fibromyalgia measure, the more their brain looks like a fibromyalgia patient on functional brain imaging. But in the same year, we published a different study showing that in rheumatoid arthritis patients that have active inflammation, this is the sedimentation rate, which some of you may know is a measure of how much inflammation you have. You get an entirely different picture in the brain when the pain is being driven by active inflammation. So there may be a future state where we could send patients for a resting state brain scan and sort of see, do you look more like this or do you look more like this? And that would tell, more so where someone's pain is coming from. Until then, just take that fibromyalgia measure. The higher you score in the measure, the more likely it is that some of these things that would work for people with fibromyalgia might work for you. There is an emerging notion that some of the biologics might be more effective than others at treating this component of autoimmune or inflammatory disorders, but right now that's really sort of speculation. For now, we really just have to treat nosoplastic pain as if it's nosoplastic pain. You will have access to these slides. This isn't going to be up very long, and so again, people, please don't try to rapidly. I guess you could take a photo of this, then you don't have to worry about writing it down. But when I put the cursor over the drug name, I will tell you the brand name of the drug, because you might only know these drugs by brand names, not generic names. This is Elavil. This is Flexeril. By the way, a low dose of Flexeril a couple hours before bedtime is one of my favorite drugs for nosoplastic pain. So if as a result of this lecture today, you think you have some nosoplastic pain, you might want to go to your healthcare provider and see if he or she would prescribe low dose cyclobenzaprine, which is very safe. It's been used for decades as a muscle relaxant, not in the way that we're using it here. Again, in many individuals, I find it to be a very helpful drug. The second group of drugs, Savella, Cymbalta, Effexor. The third one's Lyrica, Neurontin. All of these drugs have a lot of side effects. All of them only work well in about 1 out of 3 individuals, just like most drugs that we give for pain. But again, these are the preferred drugs, and the drugs that don't work for this kind of pain are opioids, non-steroidal anti-inflammatory drugs. Talk for just a minute about cannabinoids and a little bit about opioids, because again, obviously people want to hear about those topics. So I told you on my disclosure slide, I hate opioids. It's because I'm just old enough that I was trained in the era where it wasn't a good idea to use opioids to treat individuals with chronic pain. And then a couple of pharmaceutical companies behind closed doors in FDA meetings got a slight change in the label of opioids, starting with OxyContin. And they literally flooded the US market with opioids. And it led to massive overprescribing of opioids for chronic pain. Now, most physicians are sort of back to prescribing opioids rarely for chronic pain, which is where they should be. But again, there were a lot of unanticipated consequences of giving people chronic opioid therapy. The problem with opioids is they actually work fairly well when you first start taking them, but the longer you take an opioid and the higher the dose of the opioid you go to, the less well they work. And that for pain conditions like fibromyalgia, they may not work at all, and they may actually make that kind of pain worse. This is a study we did where we used a highly potent opioid called carfentanil to use what's called a PET study, which looked at the degree to which the carfentanil bound in the brain of people. You know that we have opioid receptors in our brains, in our bodies, and that's where these opioids that we release ourselves, we have endorphins and enkephalins that we release ourselves that bind to these opioid receptors in the brain. But the opioids, like if someone takes an opioid, morphine, OxyContin, Vicodin, hydrocodone, that those opioids bind to the same exact receptors. And what this study showed is that it looks like fibromyalgia itself, not in people that get opioids, fibromyalgia might be driven by release of too many of the body's own opioids. So again, a cautionary table is that giving someone with fibromyalgia-like pain an opioid may actually make the pain worse, not just not make it better. And if you look carefully at my slide here, Naltrexone, one of the second-line treatments for fibromyalgia, is a drug that blocks opioids. You've heard of naloxone. If someone has an opioid overdose, you inject them with naloxone. Naltrexone is the oral equivalent. And we're actually thinking we should be blocking opioid receptors in this kind of pain, not giving people more opioids. Cannabis, cannabinoids. I don't love using cannabinoids to treat pain. We now have funding from the National Institutes to help to look at the optimal dosing of THC and CBD or cannabidiol. We have one study in osteoarthritis that's ongoing, one in multiple sclerosis that's ongoing. We're about to study cannabidiol alone in the perioperative period to see if it is given perioperatively, if that is opioid sparing when people have surgery. So I think there's a lot of promising things with cannabinoids. And the good thing about cannabinoids is you can't die from a cannabinoid like 50 to 70,000 people in the United States are dying from an opioid overdose. This is a poppy plant, which is where opioids come from. And this is a cannabis plant. So this was meant to be a joke, but it's not a joke because, again, a lot of people in the United States are dying of drug overdoses. Most of those include opioids. What do we know about cannabinoids? So what we do know is cannabidiol or CBD is very safe, whereas THC, the psychoactive component of cannabis, really has a lot of side effects. So the first thing I would say is if you're thinking of going the cannabinoid route, you want to try cannabis or something that's in cannabis, try CBD alone. Start with 5 to 10 milligrams of CBD twice daily, go as high as 100, 200 milligrams a day. The primary reason I have people start at a low dose and go up higher is CBD is not inexpensive, and I don't want you to be spending money on a really high dose of CBD if a low dose of CBD works. But start at a low dose, go to a high dose. The route of administration makes a big difference. So gummy bears and things like that are fine for CBD. CBD, it's not nearly as sensitive to how you take it. THC, it is, and I'll talk about that. But again, all sorts of different ways. But topical CBD, the rubbed on CBD, we don't really know whether those work as well. And quite frankly, if I were you and you were trying CBD, I would take it orally, systemically, because it might be a anti-inflammatory drug, about as potent of an anti-inflammatory drug as a non-steroidal anti-inflammatory drug. But again, it may very well be helpful in people with inflammatory arthritis that the anti-inflammatory effect you might get from CBD could really be a benefit. If you try CBD alone, you go up to this dose and CBD alone isn't helpful, then you could consider, if you're in a state that either has a medical marijuana law or it entirely legalized marijuana and cannabis, you could start, but start at a low amount of THC. One of the biggest problems we see is that the THC content of the cannabis products that are being sold now is incredibly high because the recreational users want really high amounts of THC because that is what gets them high. If you're using THC medicinally, you don't want to get high. I don't want you to get high. And so, and the other thing, and this is really important, is it looks like just with opioids that a little bit of THC actually looks to work better than a lot. there's what's called a U-shaped curve, or an upside down U-shaped curve, in that a low dose of THC seems to be better for pain than a high dose of THC. So if patients don't know any better, they go to a dispensary that's used to catering to recreational users that just want to get stoned. They get some really high THC cannabis and they get high, and they don't even get pain relief because they overshot the dose that would actually give them pain relief, because a low amount of THC actually looks like a better analgesic dose than a high dose. Oral dosing is better because it lasts a lot longer, but in tinctures and sublingual are really good as well. Don't smoke. If you're using it medicinally, don't smoke. There's a lot of side effects associated with the smoking itself, especially smoking the entire plant. That may not be quite as bad if you vape. But the problem with smoking or vaping is that if you smoke or vape cannabis, it only lasts for about 2 hours. You'd have to be smoking and vaping 8 to 10 times a day. Whereas if you take it orally or a tincture, you can get away with taking it 2 to 3 times a day. But going back to what I was saying earlier, if you know the type of pain, we can actually sort of pick what drug or non-drug therapies are more likely to work. And this is what I spend a lot of my time doing. And literally, I'm using almost the exact same set of slides when I'm going out and talking to your doctors as I am that I'm talking to you today. I want to end by talking about how important non-drug therapies are, because these are things you can do yourself. And this is probably, in addition to legitimizing conditions like fibromyalgia and nociplastic pain, the other big thing that's happened in the pain field in the last 20 to 30 years is understanding how effective and how important these non-drug therapies are to use in people with chronic pain. And the reason for this is, if you start out having spondylopathy, spondylitis, ankylosing spondylitis, you have inflammation, or you start out having fibromyalgia, it doesn't matter where you start. The longer you have chronic pain, the higher your stress levels are, because just having chronic pain is stressful. You become less active, you start to sleep poorly, you gain weight, you develop bad habits that you don't even know are making your pain worse, that you like overdo it all sorts of times. And what happens is, the longer you have pain, the more of these things down here feed upward and cause nociplastic pain. And so a lot of the treatments of nociplastic pain are getting people sleeping better, start really slowly, getting more active, and then maybe in 6 to 12 months, actually starting really doing some exercise. Try different types of stress reduction techniques. And it doesn't mean that all your pain's due to stress. It just means that really trying to treat these downstream consequences of having pain. A lot of your pain, the longer you have pain, the more that your pain is being driven by these things down here rather than these things up here. And so the longer someone has pain, the more we should be targeting getting them sleeping better, getting them more active, work on relaxation techniques, stress reduction techniques. Losing weight can be helpful for certain types of pain, and different cognitive behavioral therapies and websites, self-management techniques. It's likely that a lot of the problems with long haul syndrome are this nociplastic pain or fibromyalgia type pain. Myself and a group of my colleagues wrote this editorial in the leading pain journal 3 months into the COVID pandemic, and predicted there would be a long haul syndrome, and predicted exactly what it would look like, because we've seen this kind of thing before. And a lot of the ways that people after COVID develop this nociplastic pain is there's direct effects of the virus and things like that, but some of it is it impairs their ability. They become totally inactive when they have COVID. And if they're not purposeful about becoming more active and rehabbing, then they won't ever feel like the way they did before they got COVID. And so what we've learned is that there's so many things that people can do on their own. We used to think that the main non-drug things we could do is education, aerobic exercise, Jane Fonda, Richard Simmons running around exercise, and cognitive behavioral therapy. Now we know any kind of exercise can be helpful. And when I talk to patients about exercise, I just slipped because I use the E word for you instead of the A word. The word that I use is activity, because you don't have to actually exercise very much to get pain improvement or get fatigue improvement. You have to just become more active. You have to get out of the couch. You have to move, get up 5 minutes every hour. Even if you're really sedentary, move around, and you'd be surprised at how much better. And the symptom that'll probably get better even more rapidly than your pain is your fatigue. I feel like a fibromyalgia patient a lot of days now because I spend 7 or 8 hours on Zoom. The enforced inactivity is just really toxic. And so again, try to move, try to become more active. But all these things, many of which we used to be dismissive of: yoga, chiropractic manipulation, acupuncture, acupressure, warm baths, biofeedback, hypnotherapy, massage, all these things can be helpful. And I always like ending on these two slides. And first of all, if you want to try some of these self-management techniques, our group developed a free website called Pain Guide. We got money from a donor. The donor said, do something good for people with these conditions. And we spent a lot of time and money developing this. So go to Pain Guide, look around on it, try some of the different self-management techniques. There's all sorts of different treatments you can try. You can track your symptoms. It's just vast. And now this website is being tested in a number of NIH-funded trials. And we're also then working with partners. There's a group at the University of Michigan that wants to create a version of this for lupus patients. We're making a version for rheumatoid arthritis patients. If the Spondylitis Association wants to take this website and make one for spondylitis, we'd be delighted. But we just want to get that information out there because we think that almost any individuals that have chronic pain and fatigue and some of these problems will really benefit from these self-management strategies and getting the stuff directly to the patients. A lot of these things you don't need to have a doctor or a provider or a physical therapist. We might also be learning that diet or nutrition could be helpful. These are some studies we did where we just happened to be taking advantage of the fact that there was a clinic at the University of Michigan. This happened to be for people that are morbidly obese, and they went on a very low calorie diet for 3 months. And we were just interested to see if they went on this diet for 3 months, would that improve their pain? And it did. It led to dramatic improvements in their pain and their fatigue and their fibromyalgia scores. But just to show how wrong scientists can be. So when we published this first study, it's like, oh, weight loss leads to improvement in all of these symptoms. But we were good scientists. We said, well, we don't really know that it's the weight loss. Why don't we actually track more carefully and see when in this 3-month diet, people's pain and fatigue and other things got better. And it actually occurred within a week to 2 before people lost weight. So there was something about the diet itself that seemed to be causing this. And now we're looking at intermittent caloric restriction to see if that might be able to lead to some of the same things that we saw in this study. We're trying some of the anti-inflammatory diets, but we're really interested in looking at, again, some of these factors that have been sort of classically ignored by classic sort of rheumatologists, because we've been sort of narrowly focused on the autoimmunity and treating the autoimmunity. But there's a lot of opportunity to treat other symptoms. And this is like the coolest thing. The VA medical centers in the United States, the Veterans Medical Centers in the United States are ahead of the curve. They probably have the best system for taking care of care. Look at all the things that you can get in the VA healthcare system that are reimbursed in the VA healthcare system now. And again, it's because the evidence base has gotten better and better for things like acupuncture, mindfulness. And so my biggest advice to you as patients, this is what I tell physicians too, but all of this applies to you. Take the fibromyalgia measure. The higher you score, the more you should be focusing on trying to make your sleep better, make your mood better, because we have specific treatments for these things here as well. And in some of the studies we're doing, looking at the development of new fibromyalgia in children, the sleep problems occur before the pain or anything else. And so sleep is really important. Getting a good night's sleep, restful sleep is important. Napping is not a great idea when you're tired all the time, because then you don't get restful sleep at night. But again, go to the sleep portion of that Pain Guide website that I showed you, and you'll see all different things that you can do to try to make yourself sleep better. But again, attacking some of these other symptoms is really helpful. Embrace the effectiveness of non-drug therapies, what I tell your doctors. And so I'm sorry if one of your doctors has gone to one of my talks, because if they did, then they would come back to you and say, Mrs. Jones, these therapies like acupuncture, mindfulness, massage, all these things that I showed you on the previous screens can be as effective as any drug I can give you. So why don't us, instead of keep trying drug after drug after drug, how about in the next year, you just look at this list here and you pick 2 or 3 of these things you're going to try in the next year to see if they help you. Because you say, you know, I think Tai Chi seems cool. I've always wanted to do it, or some kind of a movement therapy, but when I used to do patient care, and I know this may not sound nice, but I really got frustrated with patients that, you know, that it's like visit after visit after visit, they'd come in and they say, I feel terrible, Dr. Clauw. And I'd say, well, are you doing your exercise? No. Are you going through and do on the website and doing cognitive behavioral therapy? No. Are you, you know, did you go and try Tai Chi like I told you? No. And it's like, well, no wonder you're not better. You haven't done a single thing that I've asked you to do. You're just sitting on the couch, and I'm not surprised that you're not any better. But if you sort of embrace the fact that a lot of the most effective therapies are things that you can either do on your own or do without necessarily a prescription or a healthcare provider. In many cases, a lot of these things now can be done entirely on websites. Again, these things can be really helpful, and it sort of takes a village. What we really find is that the patients who do really well are people that find a couple of these things that work well for them, the right set of drugs, and then they really can do a lot better. And they also feel a lot better when they're playing a more active role in managing their own disease, you know, rather than it's like, you know, going to the doctor and the doctor has to tell them all the things that they're going to do in order to feel better. So I'll stop there and take any questions that people have.
Thank you so much, Dr. Clauw, for that really enlightening, wonderful presentation. We really appreciate it. We are now moving into our Q&A session. We've gotten quite a few already, but if you still want to submit your questions, please type your question into the Q&A module at the bottom of your screen if you have it, and we'll read them out loud and getting to as many as we can. Okay, let's begin with, so we, a lot of us heard a new term today, nosoplastic pain, same as central sensitization from what I understand. Can you provide a layman definition for this term for us?
It really means that the pain is coming more so from the central nervous system than either the nerve or the periphery. So it's, you know, again, going back to my guitar analogy, it's amplifier pain. It's where the pain is really coming from the amplifier. And again, just like when you turn up the volume of an amplifier really loud, and even if there's not, you know, you'll get static. That seems to be what happens in some conditions, is that that you know, basically it's basically that the people's, and part of what your amplifier setting is just the genes you're born with. About half of someone's amplifier setting is the genes they're born with. Women on average have a higher amplifier setting than men. Women have more of these kinds of pain conditions than men. We don't really understand why that is. It just is. So part of it is sort of innate, but then sometimes it can be acquired as well. Again, if people who are active and exercising regularly have a lower amplifier setting. And again, when I ask a patient to start exercising, I'm not doing that, you know, because I think they're a couch potato. I'm doing that because I know that if they get more active, that'll turn down their volume control, and that some of the pain they're experiencing and the fatigue and things like that will get better.
Thank you very much. There was a UK study this summer that involved mice that concluded that fibromyalgia is an autoimmune disorder, not something that begins in the brain. What are your thoughts on this? What are the implications of this? And how might this change how people with fibromyalgia may be treated?
It's a single study. I was a reviewer of the study. You know, it is what it is. I think most of us in the fibromyalgia field are skeptical about whether the results will be replicated. But one of the problems with those findings is it's hard to imagine and I don't want to get down in the weeds of this particular study, because most of the patients probably aren't aware of the study. But what they identified out in the periphery with respect to these different antibodies, it's hard to imagine how they could cause, for example, sensitivity to bright lights or to odors, because that is clearly a brain problem. There's no way an antibody can trigger that. So some of the classic, really key features of fibromyalgia, the memory problems, the fatigue, the sleep problems that we know are part of it, really can't be triggered by that mechanism that was being studied in that particular animal study. So the nature of science is skepticism, and just color me skeptical about, whether that's going to eventually lead us to think that fibromyalgia is an autoimmune disease. I don't think it will be in that category. There is a low-grade inflammatory process that comes with fibromyalgia, but it's quite different. The kind of inflammation we see in fibromyalgia seems to be driven more by the nerves, and it's a different type of inflammation than we see in autoimmune diseases, which is why, and again, this would make sense to people with things like ankylosing spondylitis, the fact that we see it after people have been really aggressively treated with these biologics that are potent anti-inflammatory, corticosteroids, things like that. People with autoimmune diseases got to get really aggressive treatment for their inflammation, and in spite of that, a third of them have fibromyalgia. So again, a lot of evidence that it isn't an autoimmune disease.
Interesting. Thank you so much. If you've been on opioids for a decade and want to try to come off, how would you even begin?
It depends on what dose you're starting at. If you're starting at a really high dose, you can probably come down fairly rapidly, like 10%, like a week or every couple of weeks. What the best thing to do is, for a patient, if they want to do it, first of all, let me reassure whoever asked that question or whoever is listening that if you take a large group of people that are on chronic opioid therapy and you ask them to slowly, gradually taper their opioids, only about 30 or 40% of people will have a worsening of their pain when they taper their opioids. The other 60% will either have no change in their pain, or 20 or 30% of people, especially if their pain is more fibromyalgia pain, will actually have an improvement in their pain. So to begin with, I would say that everyone that is on an opioid that hasn't tried to taper recently should try to taper just to see what happens. Because like any other drug, if you don't need to be on it, you don't want to be on it, because just being on an opioid increases mortality. I mean, these drugs just have a lot of safety issues. So slowly, gradually taper. You can print off the internet. There's all sorts of different short little things for like opioid taper questionnaires that you can take, that if you start to go through withdrawal, then you'd want to stop the taper, slow the taper, and reduce the rate of the taper. But I think everyone that is on an opioid that hasn't tried to taper should, because again, you don't know if you're one of those 30 or 40% of people in whom, the opioid really does seem to be helping the pain, or whether you're one of the 60% in whom you're being exposed to sort of excess morbidity and even mortality, i.e. an increased risk of dying, and the drug isn't helping you.
Thank you very much. When you say to get more active, do you have a gentle rule of thumb as to what to do, how long to exercise? Or is it just really very individualistic?
I use the word exercise mistakenly because I forgot I was talking to patients. So let's use the word activity.
Activity.
Just wherever you are, whatever you're doing now, just start doing more. We've done studies just showing what's called lifestyle physical activity, just asking people not even leave. If you can't leave your house, just get up in your house and move around. If you can leave your house, walking. I love walking as an exercise. Walking is a fabulous exercise for this kind of problem, because you know exactly how much you're doing. You can, whatever you can walk without hurting a lot the next day, walk that much like the first day, and then like walk a little bit more. You do that for a week, and then walk 10% more the next week. And whether you increase the speed of the walk or the length of time that you walk, you can really very tightly control. And even if you live in a climate, where it gets cold, all the malls are open in the winters for walkers. I don't know if you've ever gone, but in most harsh climates like Michigan, the malls are packed from 8 to 10 in the morning with walkers. So and it really is a fabulous exercise. But some of the different pieces of stationary equipment can be good, like ellipticals, things like that. It doesn't have to be, again, I joke about it because I'm old. Jane Fonda, Richard Simmons were the old, the classic aerobics, jumping around aerobics. And that isn't at all what people need to be doing. Just start moving and to get more active rather than the E word, which is really scary for a lot of chronic pain patients.
And I'll just do a little plug. We actually have developed we do call it exercise, but we're very gentle about it. It's specifically developed for those with spondyloarthritis. In there, we include stretching. It's segments for stretching, segments with yoga. There is some cardio and there is some strength, and you can find that on SAA's website. So that would be one other option. I'm going to group a few questions together for you, Dr. Clauw, that they're basically, they center around non-medicinal pain treatments. So what are some that you would recommend? One person asks, they've been told to use hot or cold compresses to reduce inflammation and pain. Do you think this is helpful? How do we know which one to use? A question about using TENS units. Do you find that to be effective? Cognitive behavioral things, healing or easing chronic pain with the mind. Yeah.
All of those, everything that was mentioned, with the possible exception of heat and cold, has a pretty good evidence base. Heat and cold is probably better for acute pain conditions than chronic pain. Heat can be helpful for chronic pain, but it's not, it will help with muscle spasms and things like that, but it's not really going to, do anything sort of meaningful to the pain itself. Cold is really, again, more for, acute sort of inflammatory pain to ice things down afterwards, but not generally for chronic pain. But all the other things that you mentioned, and I really do, I ask people to look at that list and say, well, which of those looks more appealing to you? Because there is also a placebo effect, and I love the placebo effect in clinical practice, because what the placebo effect really is telling us is that if someone believes they're going to get better, it actually releases chemicals in their brain that makes it more likely that they're going to get better. So why would I not have you pick from that list the thing you think is going to make you, the best? If you've seen acupuncture before and you think, oh my God, that's totally hokey, acupuncture couldn't work for me, then it probably isn't as likely to work for you as someone that says, I've always wanted to try it. And after I heard that talk from Dr. Clauw, that was the, if you will, in a good way, the straw that broke the camel's back. I'm going to go get a couple sessions of acupuncture and see if it helps me or not. But again, it's just like the drugs. When I showed you those drugs that we use for this kind of pain, and I showed you the ones up at the top, they all work in about 1 out of 3 people. And I can't tell before I give them which drug's going to work in person A versus B versus C. It's the same as the non-drug therapies. We're doing studies now to try to say, okay, is this person going to be more responsive to physical therapy or yoga or mindfulness or cognitive behavioral therapy or duloxetine? We literally are involved in studies that are being, for the first time, funded by the National Institutes of Health to look specifically at sort of precision medicine approach. When does, a non-drug therapy A work better or versus B? But right now we don't know at all. So all we can do is encourage our patients to try these things, especially since we used to, as a field, be dismissive of them. You look at some of the things on the list and it's pretty recent that anyone in mainstream sort of Western medicine embraced, things like yoga, mindfulness, and acupuncture.
Mm-hmm. Thank you very much. This next question, I'm not sure I quite understand, but I'm hoping you will. Is there a common condition triggering event? I'm assuming something that triggers developing fibromyalgia or perhaps central pain.
Yeah, it can be triggered by any number of quote unquote stressors. And by stressors, I mean certain types of infections that on their own last more than a week or two. So the common cold doesn't trigger a post-infectious nosoplastic pain syndrome like long COVID or Epstein-Barr virus or Lyme disease. The only infections that trigger along that trigger a post-infectious fibromyalgia or chronic fatigue-like thing are infections where the original infection doesn't clear for 2 to 3 weeks, and that gives sort of time for it disrupting every aspect of someone's life. It makes them sleep poorly, they become totally inactive, they feel terrible, they start to develop distress because they're not able to work, and they're wondering if they're going to be able to feel better, start feeling better, and get back to work. And so, people, what we see is that after being deployed to war, after being in a motor vehicle accident, after having certain types of infections, or after developing an autoimmune condition like a spondyloarthropathy, a sizable percentage of people that will trigger the development of a nociplastic pain fibromyalgia condition. It's probably a combination of there is a pre-existing susceptibility in that individual, plus the, again, the trigger.
Wow, very interesting. Thank you. Just have time for maybe a couple of more questions. If you don't have a higher sensitivity to other things like light, sound, etc., are you less likely to have fibromyalgia? For my allodynia, probably caused by widespread neuropathy, caused by lupus Sjogren's, I'm prescribed Grelis and I can't pronounce it. I cannot say that. So basically, if you don't have heightened sensitivity to other things, does that translate to you that you are less likely to have fibromyalgia? Do those always go together?
It's just like it doesn't mean you don't have lupus if you don't have a malar rash. So no, it doesn't. Those are just like all the symptoms we see, and not everyone has all of them. But if you have widespread pain and allodynia and you don't have sort of sleep, memory, fatigue problems, and you don't have sensory sensitivity, then I very much doubt you have nociplastic pain or fibromyalgia. So it really be that you look at all of those symptoms, the sensitivity to other sensory stimuli, the fatigue, memory problems, sleep disturbances. Those are the ones that I think are more telling. And it's really the more of those you have, the more likely you have this.
Thank you very much. Dr. Clauw, is there a question or anything that we haven't quite touched on that you think is important to close with in the last minute or so that we have?
No, I would really recommend that people go to the painguide.com website. We don't get any money for you going. It's free. We're just trying to get this information out in front of patients, have them try it and see if it's helpful. Again, and if anyone is interested in creating a version of that for spondylitis, talk to us. We'd love to, because we really are, we spend a lot of time in our research group creating non-pharmacologic therapy programs, and we're more and more mindful about the fact that we have to try to figure out ways to get these directly to patients rather than always count on health systems or providers to do that. So patient advocacy groups can be incredibly effective. We work with the Arthritis Foundation. The advocacy groups can be incredibly effective at getting this kind of information out to people. So again, any way I can be of help, our group can be of help, our website can be borrowed, stolen, made your own. I'm serious. We really don't.
That's fantastic. Thank you so much. Yes.
We really don't. Yeah, we really don't. We just want it out there. And all we ask the people, if we help them create a new website, is we'd be interested if you tested whether it worked or not. Again, which is really simple, just with web-based questions and things like that. But because we are researchers, but at the end of the day, we're just really highly motivated to get more and more people with autoimmune diseases get access to these therapies that, right, then again, a lot of rheumatologists don't think of using, just to be blunt. They're my colleagues. It's, the field I'm clinically trained in, but they often have sort of myopic view of focusing on the inflammation rather than the whole person. So,
So that was painguide.gov, correct?
.com.
Oh, .com. Okay, got it.
Yeah, all one word, painguide.com.
Wonderful, thank you. And yes, we'll be reaching out to you to discuss more.
Okay.
I'm looking to